Welcome to the next video. Today we're going to be looking at trauma, and in particular how to carry out a structured assessment of the patient admitted to the emergency department resuscitation area with a high energy trauma injury. This progresses through a primary, secondary and then tertiary survey, and we're going to be focusing on the primary survey, the purpose of which is to look for life-threatening injuries. After a primary survey, the patient would have cross-sectional imaging in a trauma centre and then have a secondary survey to make sure that no other injuries are missed. And this progresses through a top-to-toe assessment. At a later time and date, the patient can then have a tertiary survey done by a consultant to double-check that no injuries have been missed. So, focusing on the primary survey, this is going to progress through the C-spine and airway. We're then going to move on to breathing, circulation, disability, and then finally the environment and exposure. For each of these, we can think of it in a look, feel, listen, measure, treat algorithm, and therefore we can split this into a grid. Where we concentrate on the look, feel, listen, measure, and finally treat for each step. So let's talk about each one in turn. The first thing is the patient will be brought into the emergency department resuscitation area and they'll be transferred on to the trauma mat while the paramedic team and the pre-hospital team give a handover. This is crucial to listen to this as it can give vital information about how the patient was at the scene, the mechanism of injury and the observations and treatment given thus far. After that's been done and the patient's on the trauma mat, one doctor then progresses to do a primary survey. So let's take a case. Let's imagine we have a 55-year-old gentleman who's come off his motorbike and hit the central reservation. He's found at the scene with a deformed limb which has been splintered. His observations are heart rate of 105, blood pressure of 110/90, respiratory rate of 20. He's not requiring any oxygen to maintain his saturations, which are 100%. He's been given 1 gram of paracetamol, some morphine, and tranexamic acid as well. So he's brought in GCS 15 and hemodynamically stable to the emergency department. So if you are the SHO tasked with assessing this person, how would you proceed? The first thing to concentrate on is the cervical spine. This can be affected in high energy trauma, and therefore when the patient comes into the emergency department, it's prudent to ensure that they have what's called triple immobilization. This means that they have a cervical collar on, that they have blocks either side of their head, and that these blocks are secured together with tape, as shown. This minimises the movement of the cervical spine until a later date to which we can perform an examination to hopefully clear it. The patient should also have 15 litres of oxygen given to them via a non-rebreathe mask. Once this has been done, we can then focus on the airway at the same time. First thing is, we would look at the airway, and we're looking for any wounds, facial injuries, fractures in the face that could potentially compromise the upper airway, especially swelling. After we've done that, we would then move on to feel. Now, if the patient is speaking to us in full sentences, we know that they must have a patent airway, and therefore do not need to place our cheek next to their mouth to feel for any breath. If not, however, it's prudent to do this as it can give us an indication of whether they're able to move air through the upper airway. We'd also then be listening for any added or upper airway sounds. This could be stridor, which is an upper airway obstruction, or any other added sounds which may make us suspicious that the patient's upper airway is compromised. If we do hear any upper airway sounds, we can progress through a stepwise manner to try and improve the patient's upper airway. This first begins with doing a jaw thrust. If this is unsuccessful, then we can move on to adjuncts. Please note that some A2E assessments state that doing a head tilt and chin lift can also help the patient's upper airway. But in the context of trauma, we want to keep their cervical spine as stable as possible, and therefore doing these maneuvers can compromise it. Therefore, if the jaw thrust doesn't work, then we can move on to either a oropharyngeal or a nasopharyngeal airway adjunct. If these help the patient, then we can progress on to measuring and treating. If, however, these do not help the patient, then we need to escalate their upper airway management, and we would need an anaesthetist on hand to potentially place an laryngeal mask airway, or to even intubate the patient if required. So once we've done that and we're happy with the airway, we can then progress on to breathing. Again, we would look at the patient's chest to see if there are any bruises, any wounds, or any asymmetrical movement that we can see. Once we've done that, we would then feel the chest to again feel for any asymmetrical movement and also to feel for any crepitus. This could be the case if air within the thoracic cavity has escaped to the subcutaneous tissues, and this can cause subcutaneous emphysema, which gives characteristically a feeling of bubble wrap. Once we've done the feel, we would then want to listen to the patient's airway sounds. Now, in the context of trauma, the reduced airway sounds can be either due to a pneumothorax or a hemothorax. The way to distinguish this is whether there are dullness to percussion, which would be the case for a hemothorax, or whether it's resonant to percussion, which would be the case for a pneumothorax. This would have been done in the feel section. We would then want to measure the patient's respiratory rate and again check on their saturations. A high respiratory rate again suggests that there is some airway pathology or breathing pathology that may be going on. Any pathologies we do encounter, we must treat at that stage and then return to the beginning to reassess the patient from the start. So for example, in B, in our breathing, we may find that the patient has a tension pneumothorax. This is where there is a one-way valve where air can enter the thoracic cavity but cannot leave, and therefore pressure builds inside the thoracic cavity, which can compromise large vessels such as the vena cava to reduce venous return and hence cardiac output. This is a life-threatening emergency and needs to be treated straight away with a large bore Venflon in the safe triangle where a chest drain would be placed underneath the axilla. So at this point, let's take stock of our case and what the patient is currently. So we note that the patient does not have any upper airway obstruction as he's speaking to us in full sentences, although he is distressed. In breathing, we note that he's got a respiratory rate which is 20 and saturations which are 100% on 15 litres of non-rebreathed oxygen. We note that there is a little bit of reduced breath sounds at the right base and some dullness to percussion, but no subcutaneous emphysema. So the patient is fairly stable at this point of view, although we have noted some findings which are not life-threatening. Moving on to circulation, we want to first look at the patient to see if they are pale peripherally, if they are sweating, if they have an expanding abdomen, if they are maintaining their saturations or look in respiratory distress, if they have any deformities of their limbs, as these can all be areas of blood loss. In the context of trauma, the 5 areas of blood loss include into long bones, such as the femur, into the pelvis, into the abdomen or retroperitoneum, into the chest or thoracic cavity, and finally, externally, onto the floor. So looking at our patient, we want to make sure they are not sweating, that they are not pale peripherally, that they don't have any of these rapidly expanding abdomen or any obvious deformities. And that after doing that, we would then move on to feeling to see if they are cool peripherally, if they have an adequate capillary refill time, which is normally 2 to 3 seconds in the context of trauma, and to feel their radial pulse, to feel whether it's strong or whether it's thready. Now, patients who do have bleeding would vasoconstrict peripherally to preferentially perfuse central organs which are important, such as the brain, the kidney, and therefore they will be cool peripherally with an increased capillary refill time. After doing this, we then want to palpate the patient's chest and abdomen to feel for any pain, and also palpate their apex beat. We then want to listen to their heart sounds and listen for any abdomen sounds as well. In terms of measuring, we'd want to measure their heart rate, their blood pressure, and also obtain access. This would be in the form of 2 large bore cannulae into the antecubital fossa. And when we do this, we should take blood tests as well, as a patient may need treatment later on. These blood tests include a full blood count to monitor the hemoglobin, urea and electrolytes to monitor the kidney function, which can be infected, especially in hypervolemia secondary to trauma, the liver function tests, a clotting, a group and save, as a patient may need blood products later on, and therefore blood type matching is crucial, and importantly, a venous blood gas. In particular, we're looking at the lactate here, which can be increased or a marker of hyperperfusion, especially in the context of trauma. Once we've done this, we would then give the patient 1 litre initially of warmed crystalloid, such as 1 litre of Hartmann's, and assess the response to this. If the response is good, it suggests that the patient is responding to this and therefore does not have any further active bleeding, either internally or externally. After doing this, we would carry out any other treatments that are required and then move on to disability. Now, in disability, we want to look at the patient and see whether we can see any signs of obtunded mental function. So if the patient is unable to speak to you, is unconscious, this could all be signs that they have obtunded mental function. Feeling is not as crucial, and neither is listening, but we want to measure easily correctable causes of reduced mental function. This would be measuring the blood sugar and looking at the patient's pupils. Now, patients who have bleeds in their head can have signs which are displayed in their pupils, such as dilated pupils. Or if there's asymmetry between the pupils, this could also alert us to a intracranial pathology. It's important to note, however, certain intracranial pathologies do not initially present, and therefore this needs to be reassessed. For example, an extradural bleed may have the patient in a lucid interval for a couple of hours before they then decompensate. We then want to measure the Glasgow Coma Scale, or score. This is a 15-point score, which looks at the patient's eye function, verbal function, and motor function to give them a score out of 15. The higher the score, the greater the patient's mental function. A low score, especially that below 8, may require the patient to be intubated to protect their airway, as they would be unable to do so by themselves. It's difficult to treat any abnormalities in the emergency department, although some can be, such as a low blood sugar. If there are any concerns intracranially, then the neurosurgical team need to be called to assess the patient as a matter of urgency, as a patient may need to go to the operating theatre. Let's take stock of where we are at the moment. So we have our patient, we've gone through A and B, and with their C, they initially had a heart rate of over 100 and a blood pressure of 110/90. We've found that with our treatment, their heart rate has come down to 95 and the blood pressure has increased to 120/90. over 80. This suggests that they are responding to the treatment we're giving them and that they do not have any further active bleeding going on. The patient's GCS is 14 out of 15 and their blood sugar is normal at 6. We've noted that they have a deformed thigh, and this can be a cause of blood loss, up to 1.5 litres per femur. Now moving on to our last section, environment/exposure. Once we've assessed the patient A to D, we'd want to assess places that are not as easily accessible, such as the back. To do this, we first need to ensure that the patient is log rolled. This is a procedure that requires up to 5 people. The anaesthetist needs to control the head and the neck of the patient, and 3 people need to ensure that the patient's body is tilted at the same time as the anaesthetist tilts the head and the neck. The 5th person then examines the spine for any tenderness, numbness, and can palpate the spine as well. Now, the anaesthetist is in charge of this and gives the instructions on when to roll the patient, and the rest of the team follow. It's important this is done correctly, as the patient's spine has not been cleared and there could still be a spinal injury. So, we'd want to look at the spine to see if there are any bruising or any swelling. We'd want to palpate the spine. It's not as important to listen, and measuring will be done when we do cross-sectional imaging. So, having done all these, let's go back to our case. We said that we had a patient who had a left-sided thigh deformity, which was in a splint, that they had some reduced airway sounds in their right base with increased dullness to percussion, but that the rest of the examination was fairly normal and that they'd responded to the treatment of 1 litre crystalloid that we had given them in our C section. Therefore, we are concerned that this patient may have a small volume hemothorax on their right hand side and that they may have a femoral fracture on their left thigh. After doing this, we would then put them through a CT scan or a cross-sectional imaging of some description. The protocols for this are different at different hospitals and different trusts, but this normally consists of a trauma scan or a pan scan, which runs from the patient's head all the way down to somewhere between their pelvis to their toes. As you can see, a structured assessment is absolutely crucial and helps us ensure that we do not miss any life-threatening injuries as we progress to the patient's treatment. The key learning points with this are to always perform a systematic assessment, progressing through a look, feel, listen, measure and treat. Whenever any abnormality is encountered, to treat it or to deal with it there and then to go back to the beginning of the entire section and start assessing the patient from the beginning. And finally, after we have assessed the patient in an A to E manner, to then put them through cross-sectional imaging and perform the secondary survey at a later date. I hope you found that useful. Please let me know what you thought with comments below this or on my Instagram. And if you have any further suggestions of topics you'd like being taught, then let me know. I look forward to seeing you on the next video. Thank you.